Welcome to RX for Rest, the podcast that takes sleep seriously, and pharmacy even more so. I'm Adrian Zacher, and together with Gareth Evans, we explore how better sleep starts on the high street. This podcast is for healthcare professionals. It is designed to inform discussion, not to provide clinical guidance or individual medical advice. Always refer to current guidelines and use your professional judgment. Hello and welcome back to the BSPSS podcast, RX for Rest. I'm Adrian Zacher and I'm joined again by my co-host Gareth Evans, live from his pharmacy. Today we're going to talk about the position statement the BSPSS has with regard to the reclassification of, quote, sleep aids. Gareth, what do you think?
Yeah, so hi everyone. Hi Adrian. Welcome back again to our podcast at the BSPSS. So yeah, as Adrian just said, we came across, in a way by chance, the information that the Department of Health and Social Care, the DHSC, is kind of intending to reclassify certain short-term sleep aids. So yeah, as we all know, as pharmacists and people in the pharmacy world, this can mean declassification from prescription only, so POM to P medicine, pharmacy only medications. It could be from pharmacy medications, so nice tight control by the pharmacist, to general sales list, so GSL, in which case that type of medication could be available anywhere. With no controls other than what's written on the packet. And we're all guilty of not reading instructions, whatever that might be, whether it's medication or flat pack furniture. We're all guilty at some point of not reading instructions. So let's be aware that this is something that's out there. I think it is really important as the BSPSS. What we're doing is we're championing community pharmacy in the field of sleep. This is new territory, but at the end of the day, the buck stops with us potentially. We're the people that are going to be maybe being asked to supply sleep aids over the counter if it's from POM to P, and we've got certain position on this as the BSPSS, and this is
point. We have a position,
absolutely, and utilising the expertise of not just myself, not just Adrian in pharmacy and in the sleep world, but we've got all the advisors, the trustees of the charity that's the BSPSS, so from the pharmacy world and the sleep world. So we've got plenty of background and knowledge and passion behind this.
So you can find out more about the board and our advisors on our website, bspss.org. Quick plug for the website, but it's not just the two of us. We might be the face, the lead singers in the band, so to speak, but yeah, there's a great deal of skill and expertise behind us and experience.
Yeah.
So the position statement, it's online, it's on the website, and I'm going to sort of I'll shout out some of the headings. Let's just start with number one, a step backwards for evidence-based practice. What do you think, Gareth? I mean, national and international guidelines explicitly advise against the routine use of pharmacological interventions for insomnia, because what do they want? They want to see behaviour change.
Yeah, absolutely.
So the thoughts on that,
and with if we just take insomnia for example, first line treatment for insomnia being cognitive behavioural therapy for insomnia, CBTI.
Just repeat that. First line therapy for insomnia is behaviour change.
Absolutely.
It's not a sedating antihistamine.
It's not.
I'm playing devil's advocate here.
It's not. For long term use of any pharmacotherapy is generally not warranted. There's a role. And this is where our position statement really tries to clarify what's going on. And that we know that there's like you've already mentioned, sedating antihistamines just is our main example, only because we're talking community pharmacy, and at the moment really that's all we have available to ourselves in the realm of sleep treatment pharmacotherapy.
Which is one of the drivers for our previous episode, about the BSPSS, is actually changing that so that there is a valid role that progresses the patient and compensates pharmacy for their time.
Absolutely.
And it's not just about a minimal margin retail transaction. This is about using your brain, being a clinician, and actually getting paid for it. So anyway, so let's move on from that. So we've got the sedating antihistamines, but if it's, the reclassification, I would suggest that's going to mask sleep disorders. So in our previous episode, you talked about a lady that came in, pharmacy first, UTI, and you started asking some smart questions, and it's ended up with her being off to the GP with it for sleep. If you just handed out
something over the counter, some medication. Absolutely.
It misses that opportunity.
It misses the opportunity, but, worse still, it kind of masks, a potentially serious sleep disorder. So, yeah, we're going to touch on all the different sleep disorders. Well, not all of them. There's we can generally name a few on one hand, but there's, talking as we do in depth about sleep in the BSPSS, there's over 100 different sleep disorder classifications. So, we've got to be aware that, there's more to this than just insomnia.
It's not just insomnia.
And we can have quite often patients presenting with a mix of different sleep disorders. So you might have primary thoughts of insomnia, but there might be other medical scenarios surrounding sleep going on. So yeah, what we really need to make sure is that we're not going to reclassify medication that misses the step whereby we might mask serious sleep disorders or mistreat or just miss. And, with proper education, which is what we're there to do and support for community pharmacy, we see the majority of patients, we're there at the widest end of the funnel, we keep saying, and we are. So, yeah, we're there to use our education.
I'm going to move it on.
Let's go to the next one.
Yeah, so how does reclassifying potentially making these medications more available, how does that align with the drive for deprescribing and public health policy? It doesn't. That seems absolutely the wrong direction to be going. Thoughts?
Yeah, no, absolutely. I think there's lots of work going on in all different aspects of healthcare to deprescribe, to reduce polypharmacy, to really make sure the most appropriate treatments are given, and that's what NICE are there for. The NHS, we all run by NICE guidelines, and they lay down specific information surrounding our practice and our choices and the treatment that we deliver and the advice that we offer. So yeah, deprescribing,
pretty explicit. So it seems we've got DHSC going one way and NICE guidelines going another.
Absolutely.
Could read a line from it. Do not recommend is in there for it. It seems very strange.
Absolutely.
Okay.
Next one.
Next day sedation. Come on now. Next day sedation. The driving consequences immediately, or just trying to think. Yeah. These things. It's driving to work the next morning is going to be hazardous.
We're out there. That's alongside our other point of misuse and dependency. So we've got 2 points that can easily be tied together. That at the end of the day, if we make medications available, the major concern will be from P medication to GSL, because at the end of the day, we really should be looking at sleep as a medical scenario that needs proper advice and treatment under a healthcare professional, not just treating it like a minor headache. This is we shouldn't be trivializing
We're back
sleep.
to that three-legged stool, aren't we? That it's sleep, exercise, and food, and it's that simple. Sleep confounds pretty much every chronic disease. So anyway, okay. So next one.
Yeah, but we said before that. So yeah, misuse and dependency. As we know as community pharmacists, we've got lots of patients that we see on a regular basis that we already know are potentially utilising over-the-counter medications that shouldn't be used long term and yet are. So we know there's already misuse and dependency. So to deprescribe and make this more available with less control seems nonsensical. In terms of sort of driving safety, next day sedation, this is a big issue. If you've got someone, say, with sleep apnea, undiagnosed, they're effectively driving around, if they drive, on the precipice of sleep at any one moment. if we then say give a sedating antihistamine, for example, to treat insomnia symptoms that is through lack of education, or they self-treat, then that could precipitate them falling asleep at the wheel, and we all know that could be catastrophic. And that's not to say about the masking, like we've already mentioned.
And the risk of falls. So it says the elderly population, the evidence shows that the elderly population widely or commonly abuse the sedating antihistamines. And I'm sorry we're focusing on that for the moment, but and the risk of falls, it exacerbates that. And then the symptoms of dementia. It's just all manner of wrong. So let's move on.
Let's go. So the last one, melatonin. Melatonin is quite often used very successfully, and it is something that I do feel is likely to be reclassified favourably. There's good reason to do so, to put it from a prescription only medication to a pharmacy medication. And again, from the position statements we'll get to in a second, where our recommendations are, this is something that could be a favourable move. But again, we just need to make sure that there's the full controls, education and support.
The education around it.
Pharmacists.
It can't just be handed out. It can't go to GSL. It has to be some education around it about the supply.
Educated. Because there is still, the patients are still vulnerable to falls. It still should only, according to guidelines, be used short term. So we have to make sure that all the recommendations are upheld, really. That's where the medical control.
Education.
Absolutely.
Yeah. Okay. So our final position on this is that have a look at the website for the full details, but we strongly oppose the reclassification of sleep aids to pharmacy or GSL, risks of harm, guideline contradiction, undermining deprescribing, but we cautiously support a potential reclassification. I am reading this for independent, non-product led training, and the melatonin it's really a positive move that could be, if it's done sensibly.
Well, I think just to sum it up, the use of any medication sensibly and with the guidelines and with education is always, if we say always appropriate, if we're within the guidelines and it's appropriate, then it by definition it's appropriately used. And so with the controls and education, then there would be no difficulties. I think our overall concern is where is the education likely to be coming from? How is it to be delivered? And like we've said, if it's from pharmacy medicine to GSL, then it's very difficult to get that very important education off the back of a packet to a patient that's naive to the seriousness of sleep issues.
Okay, so you heard it here. RX for Rest, BSPSS podcast. I think we'll wind this up and say thank you very much. Thank you, Gareth, and sleep well, everyone.
Yep.
See you at the
next
one.
Thanks, Adrian. We'll see you soon.
Take care. Bye-bye. That's it for this episode of RX for Rest. We hope it's given you something to think about or even sleep on. If you enjoyed it, tap follow and share it with someone in pharmacy who's ready to take sleep seriously. And if you've got thoughts, questions, or just want to be part of the conversation, then join us on LinkedIn. Come find us. See you next time.